Audio is really bad. Please type in the question box and let Katie know, and then maybe we can get interrupted and do something about it. I should admit that this is my first time ever delivering a webinar. I deliver many lectures, presentations, educational sessions in my time, but I've always been able to see my audience. So this is a little bit different for me. I get no cues from anybody as to whether I am making sense to you or boring you completely. So as I said, it's a bit of a challenge, but we'll all muddle through it together. Just to supplement a little bit from Katie's introduction, I am a retired member of the Canadian Forces, a retired physician, but I emphasize the word retired. I do nothing really terribly productive at the moment, and unlike your previous presenters in the FLS work series, I do not work intimately with FLS on a daily basis. So the nits and grits of the fine details of how a particular FLS model is working in a particular place, I'm probably going to be ill-equipped to answer. And with that kind of as a disclaimer, let's kick it off. There's just the title slide, and we'll move through that. These I've borrowed from previous lectures in the FLS work series, and I don't know if anybody or all of the people on the call were participated in those. But just to re-emphasize why we are doing all of this, it's to attempt to address what's become known as the post-fracture care gap, that fact that somewhere around 80% of patients who sustain a fragility fracture do not get investigated or treated appropriately for osteoporosis at the time of the fracture. And there's many reasons for that, and I think Diane in the first lecture went through a lot of that. But that's an opportunity missed that would make a difference in the lives of these patients, and actually would, as we'll see further on down the road, could make a difference in the operation of your healthcare system, either locally or on a national level. And the best way that we know at present, and there's a pretty extensive body of research in multiple countries backing this up, is that the best way at present to close this post-fracture care gap is something known as Fracture Liaison Service, or FLS. Sorry about the acronym. It's going to appear everywhere. It's a name that most people in North America are not terribly happy with because it doesn't actually, it doesn't resonate. It doesn't produce a nice mental picture, but it is the one that is used everywhere in the osteoporosis world, and that has become, in wide use over the last sort of 6 or 7 years. It is pointless for us to try and change it now. We just have to learn to adapt to it. And it described the I's as in what the intervention does. Does it identify all the patients? That's the first I. Does it investigate them appropriately? The slide shows BMD, but that's really a determination of their risk of future fracture, whether they're at moderate or high risk of going on for another fracture. And the initiation is the third I for osteoporosis treatment. And the outline of what I'm going to cover tonight, and hopefully I intend to speak for 35 or 40 minutes, and then we'll leave some time for questions, is about the health economics of FLS. And I hope there are no sort of PhD health economists on the call, because the shallowness of my comfort level will probably become evident to a true health economist. I consider myself an amateur health economist. Show you how the FLS, as you design it in your location, can be made as cost effective as possible. Talk about building a business case for your FLS, and how some of the resources that Osteoporosis Canada has can help you do this. For many people who are actually frontline workers in healthcare, this is a daunting thing. You're not administrators, you're not bureaucrats, you don't necessarily speak business case ease. And unfortunately, business case ease is a language that varies a little bit from place to place. So that we can only go so far as to tell you what you must put in your business case, because every place is a little bit different, and some tips on how to pitch it, how to get from sort of a good idea in a document to a decision. So on to the health economics. This is a generic slide showing you how you go about what health economists do and the clinicians they work with when they're faced with assessing a new health technology. And technology doesn't mean that it's like, it doesn't have to be information technology. It doesn't even have to involve a piece of equipment. FLS is a technology that is really a way of organizing care or delivering care. This way of analyzing things really started in the drug space, like with comparing cost effectiveness of various medications for various things, but it's been generalized over time. So you always compare the new thing to what the Brits always call usual care, or the standard of care, the way things are being done now, and you assess whether it works better or works less well. And the clinical effectiveness is always step one. There's a truism in health economics that nothing that is not effective can ever be cost effective. So you have to understand that it actually does something constructive. And then you look at the cost. And the new way can cost more or it can cost less. And then this is fairly blindingly obvious when you think about it. And there's my cursor. So what do you mean for working better when you're talking about fracture care? The first thing, and this is especially relevant in hip fractures, is this is an approximate cause of death in a substantial fraction of people. So lower mortality is a big thing. Fewer repeat fractures is also a big thing. It produces less pain, leads to better mobility, allows people to remain active. They're more likely to retain their independence, so they stay in their own homes. They don't get transferred into long-term care as often, and they pose less burden on their families or other informal caregivers. And all of these benefits in health econ speak can be translated into something known as QALYs gained. Now, QALY is a quality adjusted life year. It's a way of assessing not only survival, but how the quality of that survival. So a year in perfect health would rate as 1.0 of a QALY, whereas, for example, a year as an insulin-dependent diabetic might score 0.75, depending on your context. Many PhDs have been written and awarded on the basis of just about every word I've said in the last 2 minutes. So this is several miles wide and a quarter of an inch deep. But and there's certainly lots of controversies around QALYs, and you don't have to Google terribly hard to find out some of them, but it is still the measure that is most currently used in the health economic literature, in the cost effectiveness or cost utility analysis literature. Why are QALYs so important? They're important because they allow you to judge the relative worth of interventions for one kind of problem against interventions for another kind of problem. In the early days of health economics, it was all sort of about different treatments for the same thing. So what did it cost you to prevent one heart attack? What did it cost you to prevent a cancer death? That's kind of the early days. But how do you judge the relative importance of heart attacks versus cancer deaths? That was not possible until the advent of QALYs, or a related concept known as disability adjusted life years. So you needed a measure that could translate across different kinds of health problems. And that's what the QALY lets us do. We're not going to get too far into the weeds with those, but just it's a concept to keep in the back of your mind. When you sort of take those kind of two things, whether it works better or less well, or whether it costs more or costs less, you end up with kind of 4 possible combinations of those two. And if something works less well, remember that nothing that is not effective can ever be cost effective. And particularly if it costs more than the old way, you definitely don't do that. If it works less well and it costs less, there are some limited situations where that might be of interest, and that's largely in the developing world that are dealing with very, very limited budgets. In Canada, it would be political and sort of management suicide to actually openly advocate for anything like that. What you often find when you do this kind of work is that something works better and it actually costs more. And that gives you a problem. How much more for how much better? And we'll get into that in a little bit in more further down the road. But what's as clear as day, or should be, is that if it works better and it costs less, and there are very few new interventions that actually do this, but any new technology that works better and costs less should be implemented. You should definitely put this into your system. You can translate that into something known as a cost effectiveness plane, which just takes those two aspects and puts them on orthogonal axes and gives you 4 quadrants. The less effective, more costly, the ethical and political, which is the no-brainer don't, the ethical and political minefield of doing less with less. And the lower right-hand quadrant, the no-brainer that you do, which is, you'll see a term in the literature if you get interested and read it. This is known as being dominant. Any intervention that falls in this quadrant is dominant over the current way you're doing things. The other thing you can see there, and I'm fiddling around with the mouse just to, are the dashed blue lines in the top right-hand quadrant. Those are conceptual views of a threshold that exists for how much more are you willing to pay for something that works better. And that's an eternal question. It's something that policymakers in the healthcare field wrestle with all the time. And it's a subject of interest to drug manufacturers and people who sell medical devices, because they want to know how to price their innovation so that it will get adopted, but also so that they make the maximum return on investment for developing this thing. And there's a wealth of literature surrounding decision making in that quadrant, which we won't have to get into too much or really at all tonight. We'll just move on. So what do we know about the cost effectiveness or the health economics of fracture liaison services? Thankfully, for those of us working in the Canadian context, there is actually Canadian-specific information out there, because for some reason, policymakers particularly like to see domestic or homegrown data. It's very reassuring, and there's practical reasons for that, which we'll get into it in a little bit later. And you can read the slides as well as I can. This was an inpatient-only fracture liaison service, so focusing on hip fractures who were admitted from Edmonton, Alberta. And this paper was actually written before the term FLS came into wide distribution. So that's why it's called using a case manager, but that is essentially an inpatient FLS. And it clearly showed in that case that substantial cost savings. So that means this is, and you also see the phrase, the intervention dominated usual care. So those two things are important terms in this. Dominated usual care, substantial cost savings. So you're in that lower right-hand quadrant. There is no question that this way of doing business is far better than the old way of doing business. And we'll move on to the next slide. Another longish paragraph for you to read while you're somewhat listening to me. This was from St. Michael's Hospital in Ontario, again a few years ago. So this is called a coordinator program, but it was in fact an inpatient and outpatient FLS implemented at St. Michael's Hospital. And I'll bring your attention to a couple of things. Yes, they also found it cost savings. You will see in other documentation, if you dig into the weeds of what Osteoporosis Canada has on its website, a reduction of 3 hip fractures in the first year on the basis of 500 patients. So that's a key fact that we use to underpin some of our projections and calculations. And you may need to know this as you develop your arguments to support an FLS, that hiring a coordinator, again, an FLS nurse, read there, is a cost-saving measure when the coordinator manages as few as 350 patients annually. Now, those are not, of course, 350 hip fracture patients. This was an outpatient FLS, so an outpatient and inpatient FLS. So most of those are probably not hip fractures. They are wrist and humerus and fracture patients. And as I said, greater savings are anticipated beyond the first year. So the longer you keep going, the more money you save. And again, it uses the terms a dominant strategy. International data is a little harder to interpret in the Canadian context, but this group in Glasgow is one of the world's leaders and longest sort of running FLS programs. This is 8-year data. They prevented 18 fractures, of which 11 were hip fractures, in the cohort of 1,000 patients. So per 1,000 patients followed over 8 years. Not all of those patients were followed for 8 years, but the program had been running for 8 years. 18 fractures were prevented, and this was a dominant strategy, again, dominant as in cost savings. They did a lot of sensitivity analyses. We'll talk about that a bit. And the sensitivity analysis is just really a way of handling uncertainty in economic analysis. So what if I'm wrong about something, or what if the drug company pushes the price up and so the drug costs more? What if actually the published statistics about how much it reduces future fractures are off by a bit? So that's why you do sensitivity analysis. An FLS was not cost savings, as in all cases, was high, but even then it was highly cost effective. So you're bumped up into the lower part of that upper right-hand quadrant. There's an Australian article, which I included in here. In the Australian setting, they did not find it cost-saving right away. What they found, though, is that if their assumptions on costs, or the Australian cost structure is significantly different from other places. So if they plugged in the costs of certain interventions that were prevalent in other systems, and they mentioned specifically Britain and Belgium, then it became a cost-saving intervention. But they did say it's a cost-effective intervention, and it was robust. That means it was still cost-effective under a wide range of plausible assumptions. So there's pretty good consensus out there. I'm going to make a bit of a digression here and say, I don't know if anybody's on the phone from Alberta, but the same lead author that you saw there on the Alberta study that I cited a little while ago, published one this year about the catch a break program in Alberta, which is really a one-eye model. And if Diane Theriault's on the phone, she'll probably throttle me for saying that. But if any of you are pitching FLS anywhere, somebody is going to bring up this study, because it showed this one-eye model, catch a break model that's in place in Alberta, to be cost effective. Now, I want to offer two things, or two words of caution about that. Remember that cost effectiveness is really a ratio. It divides cost by how much you achieve. And if you cost very little, you don't have to achieve very much for it to look cost effective. There are famous cost effectiveness studies about smoking cessation, which suggest that a family physician who says, you know, you really should quit smoking, is a cost effective intervention. It doesn't cause many people to quit smoking, but it costs essentially nothing. So it's not hard to make that cost effective. The other word of caution about Alberta's Catch a Break program is that, as far as I'm aware, at least in Canada, it's the only one-eye model that's been shown to have a statistically significant increase in treatment rates. A similar service in Manitoba moved the needle not at all on closing the post-fracture care gap. So I think the jury is, I'd be very, very cautious about hitching your wagon to a one-eye model, because just because something is cost-effective, if something else is out there that is equally or more cost-effective and achieves more clinically, that is the way, sort of ethically and responsibly, that you should go. So what can you do when you're sort of looking at designing an FLS to try and make yours as cost-effectiveness as possible? The first two bullets are just kind of ways of saying you can't always take the results of one study and say it's going to be the same here, because both absolute and relative costs are different from one system to another, from one province to another, for that matter. We use sensitivity analyses, which is not the same as sensitivity and specificity of a lab test, for example. It's a statistical term used in health economics to find out which factors do and do not move the needle for the cost effectiveness results. Interestingly, when you do that, you find that the cost of the medication that you use is actually not that important, but how efficacious it is very important. How much fractures cost to treat in your system is important, but the most important cost, the most important factor in Canada that drives whether you are cost saving or merely cost effective is the cost of your provider, and particularly the cost of provider per patient treated. So you need a provider who is, what this really says, translated into sort of taken to an extreme, is that if you decide you want to have an endocrinologist run your FLS, and that endocrinologist wants to take 5 hours to see every patient, this is not going to be cost effective. That's one main reason why we're so focused on nurse practitioners for a 3-eye FLS or nurses to run a 2-eye FLS, because it's kind of a sweet spot for cost versus ability to actually get the job done without requiring huge referral resources. And they can't take forever talking to each patient. They need to take as much time as they need to communicate, but it's health human resources are a significant cost driver, and there's kind of no time for a whole lot of chit chat. Otherwise, your efficiency is going to go down. Unfortunately, even though there's abundant evidence that you're going to be cost saving or at worst cost effective, that doesn't mean it's going to be easy to implement. Cost effectiveness is based on cost per quality. It's independent of scale, and it's a steady state concept. So you take all the costs that it takes to get this thing going, and you amortize it against all the number of people that you're going to treat over time. And when you talk about savings, that's as compared with usual care. And when you talk to somebody who's managing a budget, the scale matters a lot. So a cheap intervention that everybody in your population is going to require is still an expensive intervention. And everything requires money to get going. So those are your upfront costs. And, the HR controls is there because some things look cheap, or some systems have a relatively easy time with money, but have severely constrained people. And for a manager, savings is not savings compared with usual care, it's savings compared with this year's budget. So the business case helps you bring both of those into focus. And this slide is just a way of demonstrating that difference between, when we talk about savings here, we're talking about this difference. You bend the curve down when you institute an FLS, because given demographics and the aging population, every year that goes by, you're going to have more and more fractures unless you have an FLS in place. Eventually, some systems like Glasgow have shown that this red curve will actually trend and start to have a negative slope, will actually trend down. But at least in the beginning, you're talking about bending a curve down, not sort of getting below this baseline that existed back here sometime in the past. And those are just Osteoporosis Canada's projections showing a pretty linear march on number of hip fractures from 2007 through to 2035. And that's driving a lot of the costs that we're seeking to bend. So getting on to the business case, and I've got to move a little more quickly. As I said at the beginning, every system is different. Some may have a pro forma, a template for a business case, and you should, of course, adhere to that if there is one, and find examples of other people's to help you get through it. The next that paragraph down that you can see is just sort of paragraphs or sections that probably should be in the business case. I'm going to highlight a little bit this part. It's not always obvious, and business cases can seem kind of sterile, but even bureaucrats are moved and influenced by really compelling personal examples. And most templates will allow, even if it's not sort of in the absolute kind of core text, you can always put in one of those little side bubbles with 3 or 4 bullets describing a real patient who, for instance, fractured 5 times before they were finally diagnosed with osteoporosis, and then, the terrible, the excess pain and suffering and uncertainty and all of that was exemplified by this case. Those kinds of individual examples tend to resonate with people much more than statistics and talking about cost savings, even with heartless bureaucrats. So I included patient example there. And then, it's really in order to persuade, this document also has to educate. So the people who read this probably won't know anything about the care gap. They won't necessarily equate. Everybody knows intellectually that the population's aging, but they don't necessarily know that that's going to drive their numbers of people that need OR time to pin hips in quite the way that we understand that. They don't know anything about FLS probably. They haven't heard, don't understand the acronym. So all of that needs to be explained succinctly and clearly and with and hopefully in about 4 pages or less by the time you're done. So that's quite a lot of work. And before you even sort of get there, it's helpful if you can dig up some key numbers to make it really relevant or to really relate specifically to your system. So we can help a little bit with this, and I'm going to try and, how do I get my pointer back? I'm not sure. If this doesn't work, I'm going to be...
Maybe press escape, Hillary.
What's that? If I press escape?
Yeah, press escape on your... Oh, no.
I want to keep your ink annotations. Discard. Okay.
Nope,
now,
that took you out. Sorry.
It dumped me out, so I'll
from current slide.
Wait, right. Now we're good. Okay.
Okay.
Don't try to do too much with a highlighter. As I said, first time for everything. So this is just a hyperlink that's taken us back to the Osteoporosis Canada website into the FLS tab. Oh, and I need to get rid of this. Scroll down, and you'll find the tools and resources on the right-hand side. Click on that. And if you scroll down again, you will find Appendix B, fracture incidence and cost by province. Those can help you fill in some of those numbers that you might be missing. Appendix F, potential cost savings of FLS by province. And Appendix E, a generic business plan template. I'm not going to open Appendix E because I'll tell you it's a little bit daunting to look at, and it's probably longer than you want. Part of the reason it's longer is it has 4 pages of reference. You can tell it's written by somebody who otherwise writes scientific papers because everything is perfectly documented in terms of the reference list. Inside both Appendix B and Appendix F is a link to an Excel spreadsheet where you can put in your own numbers of hip fractures and derive from it some estimate of how many full-time equivalents you're going to need to run an FLS, how many hip fractures you can expect to save in 1 and 8 years, and how many dollars you can expect to save in 1 and 8 years. I think it's a useful tool. Unfortunately, I don't really have time to go through too many examples with you, but it is there. And I included that as a way of showing the appendices in case the hyperlink didn't work. As quick and dirty rules of thumb, without sort of going through the use of the Excel spreadsheet that's embedded in those tools. If you have about 150 hip fractures in your hospital or your health authority, you need about 1 FTE, full-time equivalent, to run your FLS as an outpatient FLS. And you can expect, based on sort of the salary and a few other requirements of the FLS and the increased number of prescriptions for bisphosphonates or other medications, and perhaps an increased number of bone mineral density tests, all those considerations, you can expect to break even after a year and become cost saving thereafter. So that's kind of the 2 quick and dirty rules of thumb. Where's my advanced thing has gone away. There it is. If you were around for Sonia Singh's talk, she gave sort of half the rest of my talk because she had some very nice slides as to how they were able to become successful. And she passed on that data was important, and they had results because they had had some temporary funding beforehand. The cost effectiveness modeling, which we can help with, and the fact that they had patient partners, and that speaks to sort of the getting away from the cold, hard bean counting approach and making it real for people. I've got a few slides on tips on pitching your business case, and these are really, the bullets are somewhat self-explanatory. Don't rush to make your pitch. Make sure that you're absolutely ready before you get there. And there's sort of time spent preparing is probably going to pay you back. You need a team, and again, Dr. Singh gave you an idea of how many people are on their team. The medical director, who may or may not be a family doctor, osteoporosis specialists, whoever's working in your jurisdiction, orthopedic surgeons, radiologists, nurses, administrators, patients. Don't be afraid to make it a big team. Every health jurisdiction, every health system has something that is kind of flavor of the month. Whether it's falls prevention, whether it's a focus on chronic disease management and moving away from sort of episodic care, whether it's seniors' issues and aging in place. Find a hook for your FLS to whatever is flavor of the month in your health authority and leverage that shamelessly. And that should be fairly easy to do for most of the hot button issues that come around. Understand the cycles in your health authority. The budget cycle, the business planning cycle, and those two may be linked in some authorities, and the strategic planning cycle, which is usually 3 or 5 years as opposed to an annual business planning and budgeting cycle. take a look around again and identify likely allies. See about adding them to your team, and that's what I mean by see bullet 2 above. Less obvious, but probably even more important, is to identify adversaries. Whose toes are you going to step on by doing this? And this could be anybody who has a pet project that they want funding for, and so those 2 funding requests are going to be in competition. Or, some family physicians may not want to give up this much authority or autonomy and control to a nurse practitioner. So there's a number of reasons why people might throw up roadblocks, but you have to talk to them ahead of making your final pitch, if only to anticipate and have a sort of a dry run at answering the questions that are going to be asked by these people. This is kind of one of the most important things. When you make your pitch it at the right level. There's several, hierarchies have many tiers, and it can be difficult sometimes to figure out where to head it for. It's actually better to go too low than too high, because if you do a good job pitching to an administrator or manager who's too low on the totem pole, they may, if they're interested, they may come on board as a member of your team, and that can be very helpful because they speak the management language probably much better than you do. The sweet spot for the correct level to pitch at is the manager whose area of control includes not only where you're going to work, which is probably in the outpatient orthopedic clinic, but it could be on the wards as well, includes those areas and the areas where the benefit will be felt. It is really hard to convince somebody to start a program if some other manager is going to get the saving, is going to reap the savings. This may not be possible to do, but if you can, it's worth doing. So the areas where the benefit will be felt will be the operating room, will be the emergency department, and of course the areas where the work is done are the outpatient clinics. So if you have a manager whose scope includes all of those, that's really helpful. If you pitch it too high, like if you go to the CEO, or even worse, if you go to the Minister of Health, they may well think it's a wonderful idea and jump right on board, but the challenge with them sort of giving the thumbs up and saying, make it so, is that other layers of management in between may well put their own spin. You're kind of playing broken telephone on the way down to the right level. And we've seen it happen where a successful pitch for a 3I model at the very, very top of a food chain and by the time you get to the bottom, it ends up being a 1I model. Or better, but still not perfect, is that a successful pitch for a 3I model with 100% coverage only ends up with enough resources to allow for sort of 50% coverage, and I have an ethical issue with that. When you can't afford to provide this kind of service to everybody, how do you decide who's in the 50% and who isn't? You got to be persistent, because everybody's busy, and everybody's heard this. Managers they get multiple of these on a kind of weekly to monthly basis, so they're probably spinning from people giving them wonderful ideas. So make their job as easy as possible for them. When I say realistic sources of funding, every complex undertaking that I've ever been part of has lapsed money, and when you get something approved, it's highly unlikely that you can actually spend the money that you've been given. If you can get somebody to own up that this is happening, like for instance, somebody may have been given the go-ahead to institute a certain program, but they are having trouble hiring, or they're behind schedule on some IT project or something that's essential to them moving forward. So if you can find out that some of these things are out there, that's a source of funding that is relatively painless for a manager. Similarly, look for positions that are on the org chart. They already exist but they're vacant. Ideally, they have been for, say, a year or so, and ask if they, propose that those be used at least while you get up and running. If you're really desperate, and probably this applied to the federal government more than your situation, but we often have hiring freezes on. Well, we don't have freezes on expenditures, and this led us to use contractors, because technically you're not hiring a public servant. Typically they cost more and produce less, but if you're desperate, it can be an option. You're probably going to have to give this talk more than once, and other people have been successful using either money from their hospital foundation to get a pilot up and running, or from a corporate sponsor, and I'm thinking about Diane out in Dartmouth, but that was an insurance company, which is a better corporate sponsor than a drug company. I would actually run away from using drug company money as a corporate sponsor, because there are enough people out there who think osteoporosis is kind of basically that advocating for osteoporosis is only done by people who are shills of drug companies, and we don't need to reinforce that erroneous perception at all. Every FLS that's gotten up and running in Canada has faced the need to re-justify itself, and the results you achieve in your first year are going to be really important to secure ongoing funding, so you've got to track this carefully. And when you write your business case, make sure you spell out how you intend to do this. So quick recap, 3I or 2I FLS, as I think we all understand now, is the most clinically effective way to close the post-fracture care gap. FLS is actually cost-saving in the Canadian context, and it also saves other important things than money. Provider cost per patient seen is the most important variable for you to manage when you design your FLS. But even when you have all these kind of ticks lined up, implementation is still difficult. A business case is an essential tool for persuasion, and include the human face in the pitch, if not in the business case itself. So I'll hold there for questions.
Thanks so much, Hilary. Just while we're waiting for any questions to come in, feel free to type anything that you want to ask Hilary into the chat box, and I'll send it to her and also read it out. But while we're waiting, I thought I would just mention that we're going to be taking a break from the webinar series for the summer, and we will be back in September, likely closer to the end of September, but we'll send out that notice through Liaison newsletter, and if you're on the FLS network, you will be getting that. Our presenter in September is going to be Joanna Sale. She's a researcher with the Ontario Osteoporosis Strategy and the St. Michael's Hospital. And St. Michael's was actually the first, they had the first FLS in Canada. And the topic she's going to be covering is why the care gap persists, and some of the challenges and patients' perceptions of fragility fractures, which are barriers to treatment. So, no questions have come in so far. We'll just give it a couple more seconds, maybe. Thank you again so much, Hilary. That was a great presentation.
Yeah, and if anybody online thinks of anything, sort of, if anything occurs to you, 10 minutes from now or in a nightmare tonight, you can always contact me through Katie, and if it's not best answered by me, Katie will know who else to talk to.
Yep, that's right. So, I guess there's...
So I guess I'll just thank you for listening, and Katie, I guess we can sign off. Yeah,
there was for you. Chloe Kilkenny says, thank you, enjoy the summer, and Diane says, thanks, this was great. All right, thank you so much, everyone. Thank you again, Hilary.
Cheers. Bye-bye.
Bye now.